Biomimetics begins with falling in love with nature. And in order for you to create bioemulating restorations, we need to consider both the physical and optical properties of the substances that we are trying to reproduce, namely dentine and enamel. As we know, dentine is a collagen-rich organic substance with many dentinal tubules. And those dentinal tubules are quite irregular. So when light hits dentine, we get an increase in light scattering. And as a result, dentine is quite opaque. Dentine is also quite a dull surface, and it has fairly poor wear resistance. On the other hand, enamel consists of more regular hydroxyapatite crystals arranged as prisms. And as a result of that regularity, light transmits, or there is increase in light transmission through enamel, resulting in a degree of translucency. Enamel is also highly polished, and it has excellent wear resistance. So it makes absolute sense to replace dentine with hybrid composites and enamel with microfilled composites. Why? Well, hybrid composites have a mixture of filler particle sizes, so we have some large filler particles that give us strength and opacity. We also have the smaller filler particles, allowing the material to be more handleable. Hybrid composites give us chromacity, they give us opacity, and it gives us strength, being a very, very suitable dentine replacement. Microfilled composites, on the other hand, have very small filler particle sizes. And as a result of that very small filler particle, microfills are excellent at enamel replacement. The reason being, they polish very, very well. There's no material that polishes better than a microfilled composite. It's got excellent wear characteristics, and it's inherently translucent. And those properties make microfill an excellent enamel replacement. However, one of the biggest disadvantages with microfilled composites is that they have very poor fracture toughness. So under the wrong stresses, in the wrong direction, you can expect chipping or mechanical failure of microfilled composites. But hey, enamel is also quite weak. That's why we get enamel chipping. Feldspathic porcelain is also quite weak under tensile stresses, but we still use feldspathic porcelain to layer metal and ceramic copings. So the key thing when we're using microfilled composites, provided they are supported appropriately by the underlying hybrid, they perform absolutely phenomenally. I'm going to spend the rest of this lecture showing you the three main layering techniques that I use in clinical practice to produce the results that I'm going to be showing you. And hopefully you can put these three layering techniques into practice tomorrow just to raise your composite game. You'll see that morphologically, these three layering techniques are fairly similar. The only difference between layering technique number 1 and layering technique number 2 is the shades of composite that we use. We start off with the palatal shell, we restore the dentine, and then we layer that with a microfill. So let's begin with showing you a case treated using layering protocol number 1. This patient, Jay, she attended the practice complaining of failure and chipping of her composite restorations. And she wanted me to restore the form and function as minimally invasively as possible. So here you can see a close-up image showing mechanical and functional failure of these restorations. We isolate the sextant, or the arch in some cases, using rubber dam and floss ligatures. And then we remove the defective restorations and then perform any micro and macro preparation. So in this particular case, we would sandblast the facial surface and the internal surfaces using an aluminum oxide sand, and then continue with the etching and bonding procedure. Here is a palatal view of both centrals, at which point I realized I should have gone indirect. But you can see there's a degree of buildup on the upper right one. So the process starts by adding some composite onto a silicon index that's created from a diagnostic waxer. In a case like this, you'd want to restore the axis cavity to begin with, up until we reach the palatal surface, then we can re-establish the palatal surface using one of these silicon indices. Going back to the materials, we restore the palatal surface using a nanocomposite. Once the composite is placed onto the silicon index, we offer that up into the patient's mouth, and then using either microbrushes or modeling brushes, we then ensure that the composite is correctly adapted to the palatal surface to ensure that we have a hermetic seal. We then, like your other restorations, remove the silicon index very, very carefully, and we should be left with two shelves that provide us with a framework onto which we then go on to do our dentine buildup and our final enamel layer. The dentine was then restored using the same shade of composite, and it would be the same type of material. So in this particular case, it's a nanohybrid. And we leave some space to be restored with the microfill composite. The microfill is going to give us the translucency and the polish that we're after from an enamel replacement. Once the centrals were restored, we then repeated the process to restore the lateral incisors. So once again, we use the silicon indices and apply some nanocomposite onto the silicon index, offer that up into the patient's mouth to restore the palatal and dentine of the lateral incisors. Following which, we then leave 0.5 millimeters of space to be restored with the microfill. Using standard finishing and polishing procedures, we obtained this result. Now, the success in such restorations doesn't actually come from the color. In actual fact, the success comes from the form, the shape, and the polish. So my general rule of thumb is the more teeth I'm going to be treating, the more I'm going to simplify the number of shades that I'm going to be using to treat that particular case. The biggest benefit of using microfluid composites, the market leader being Renamel, is that when you blend and sculpt the material onto the tooth structure, you can't see where the composite meets the tooth. What about lower incisors? Well, as I mentioned, microfills have poor fracture toughness. So we generally don't use microfilled composites in areas that are subjected to higher occlusal loading. So we wouldn't use a microfilled composites for posterior teeth, and we wouldn't use them for the palatal surfaces of uppers, and we wouldn't use a microfilled composite for the restoration of lower incisors. So this case, which is part of a full mouth rehab, we need to make a decision as to what material we're going to be using. And in such cases, the best material would be a nanohybrid. How was this case treated? Well, initially we get a diagnostic wax-up made, and from the diagnostic wax-up, we then create a silicon index. Now, it's quite useful to instruct your dental technician to do the diagnostic wax-up in a color that is different to the stone, so you can assess the amount of composite that you require during your build-up process. When you create the silicon index, once again, you want to make sure that you record the occlusal surfaces of at least 2 teeth either side of the last tooth that you're going to be restoring, as this provides us with cross-arch stabilization with the silicon index in place. Now, when you ask a technician to do a diagnostic wax-up, they spend majority of the time putting in the anatomy on the labial surface. But in actual fact, when we're doing direct restorations, we want the detail to be on the lingual surface, because the silicon index is there to record the incisal table, the lingual surface, and the interproximal embrasures. And we need those areas to be as absolutely crisp as possible so the silicon can pick up the detail, allowing more detail in your final restorations. We then trim the silicon index so we know that in the mouth it doesn't interfere with the rubber dam clamps. And we're now ready to restore those, the lower anterior sextant. So here we isolate once again with rubber dam and floss ligatures. A shallow bevel preparation has been prepared in the interproximal area, and again a slightly longer bevel preparation on the facial surface, just to improve the blend between the nanocomposite and the tooth structure. We then check the fit of the silicon index, and it allows us to visualize the degree of buildup that is required. Now, when treating multiple teeth, in order to increase or fasten up the procedure, it's quite useful to treat every other tooth. So we isolate adjacent teeth either using acetate matrices or we can use Teflon tape. We then etch and bond using normal procedures, and we're then ready to start the build-up. So we apply the nanocomposite onto the silicon index on all three. We offer the index onto the teeth. We use an IPCL, which is a small, sharp instrument to ensure that the composite is confined to that tooth. And then we light cure these, leaving us with these shells onto which we can then go on to build up the dentine and the final enamel. Quite often, the composite may bond or stick to the adjacent tooth, so in such cases we can just pass through a serrated strip. And what we then do is insert some acetate matrices, stabilize them with some wedges to help us to create a tight contact, and we're now ready to restore the remainder of the buildup. So in cases like this, you'd get a single increment of composite, you would inject or place the composite on the facial surface, use a flat plastic or some modeling brushes just to blend the material onto the tooth surface, and then light cure that, leaving you with something that looks like this. And at this point, we're then ready to restore the other teeth in exactly the same fashion. So just remember, we're still using a single shade of composite, a single type of material, a nanofill. So the process was repeated for the remaining three teeth. And once all thoroughly light cured, we can then go on to finish and polish the restorations using a combination of finishing discs, rubber points, and we quite often use a number 12 scalpel just to remove any parts of flash. So here's the end result of just using a single shade of composite. And as I mentioned, when you're treating multiple teeth, you want to try and keep the layering protocol as simple as possible. Okay? You can still obtain very highly aesthetic restorations using that single shade of material because the success comes from the shape and the polish. Let's move on to layering protocol 2. Now, morphologically, this layering protocol is exactly the same as layering protocol number 1. But instead, we're now using different shades of composite to restore the palatal surface, the dentine, and the final enamel. Now, the next two cases I'm going to show you, one of the educational objectives from the next two cases is to show you the different ways in which you can restore the interproximal areas. So let's start off with this young lady. This young lady, she just recently completed orthodontic treatment, and she wanted to improve the overall look of her teeth. So we start off with a diagnostic wax-up, perform the aesthetic, functional, phonetic assessment, and we also conduct the normal cosmetic principles of smile design to assess what changes need to be made. So we look at both the macro and micro elements. We assess the patient's facial midline, dental midline, interpupillary line, have a look at the long axial inclinations of the teeth, see what needs to be corrected. So in this particular case, you can see the lateral on this side needs further distal inclination. We have a look at the width to length ratios of the teeth, and you can see here that the teeth, the centrals and the laterals could do with elongation. But one of the problems when you elongate teeth is it disturbs the ratio between the centrals to the laterals to the canines. So quite often, a simple case that involves treating 4 teeth may start to include treatment of the premolars. And you can also see here that an improvement in the embrasure form is required. So a decision was made to treat this case very minimally invasive, completely in composite. So once again, we isolate with rubber dam, with floss ligatures tied to the rubber dam frame, and what that does, it really retracts the gingival tissues and provides us with better isolation in the cervical area. Here is the tooth preparation. All I've done here is remove the existing restorations and place a very light bevel preparation. The teeth have then been sandblasted with an aluminium oxide particle, etched and ready to receive the adhesive. So the silicon index is made from the diagnostic wax-up. We then check that inside the patient's mouth to make sure it is completely seated. First step is recreation of the palatal shell. So we apply a nano or a microhybrid composite onto the silicon index, offer that up into the patient's mouth, we light cure that, and we're left with these shells. The next decision we need to make is regarding the interproximal form. And essentially, we have two ways of doing this. Firstly is the immediate technique where we restore the interproximal straight after the buildup of the palatal shell, or alternatively, we can leave it till later. So in this case, I decided to restore the interproximal straight after doing the palatal shell. What is the process? Well, once the palatal shell is created, we then insert a matrix, and you would want to stabilize that matrix with a wedge. We then get a small increment of the composite that we're going to use on the facial surface. So this would be a microfield composite. And the reason why you do this is so you don't see the join between the interproximal composite and the facial composite. We sculpt and model the material, and then once completed, we light cure that. And what we're left with is essentially a box into which we place our dentine shades to allow us to complete the restoration. So going back to her case, you can see here what I've done is got some of the microfield composite and inserted that into the interproximal following use of mylar strips and a wedge. So now the buildup becomes much, much easier. But one of the disadvantages of using this technique is it's slightly time consuming at the beginning of the buildup. I then replaced the dentine using a slightly hyperchromatic dentine and used some white tints just to create the effects of hypercalcification. Now all we need to do is complete the restorations by applying a layer of the microfield composite. So we restore the centrals first, make sure we have symmetry between the two central incisors, then go on to restore lateral incisors, and then the canines. Then, using a selection of discs, rubber points, and whatnot, we then finish and polish the restorations to give us something that looks like this. Now, if you're going to be applying tints and effects and trying to get some incisal translucency into your restorations, there is absolutely no point in doing it unless you finish and polish your restorations as they should be. Because it's that polished restoration that allows the transmission of light that then brings out the translucency and the effects that you have just placed. The next case really epitomizes what minimally invasive dentistry is about. This young chap, one of my long-standing patients, as he was growing up, he then started to express concerns regarding the color, the shape, and the size of his teeth. So this case was treated using the classic align, bleach, and bond. Now, I'm no orthodontist, so please don't ask me any questions. So we started off orthodontic treatment where we bonded up pre-adjusted edgewise fixed appliances. We started off with a light arch wire, so an 012 in such instances, to bring about initial leveling and aligning. Following the 012, we then progress into an 016 arch wire just to help complete some of the tip expression. Once we move from round arch wires, we can then move into rectangular arch wires. So in this particular case, I moved into some 1622 transitional nickel titanium wire. And what this does is it starts to bring about torque expression. And cases are then completed with a stainless steel 18 or 1925 to bring about any finishing and detailing. Once he was bonded, we then usually whiten cases. So in this particular instance, we use 2 weeks of the Enlighten system, whereby we whiten for 1 week using a 10% carbon peroxide, and then whiten for a second week using 16% carbon peroxide, bringing us to whiter than B1. So now we're at a stage where we now need to re-establish and correct the form and function of his incisor, of his upper incisor teeth. So once again, we get a diagnostic wax-up made, and from that diagnostic wax-up, we then create a silicon index. We isolate with rubber dam, and what I've done is just to remove some of the hyperplasia, I've just prepared a short bevel preparation at the incisal edges of the central incisors. Absolutely no prep was performed on the lateral incisors. In the usual way, a hybrid composite, whether it be a nano or a microhybrid, is applied onto the silicon index. We then offer that up into the patient's mouth, and we then use a brush to make sure that the composite is correctly adapted to the tooth structure. We can use an IPCL, which is an interproximal carver, which is a long, sharp instrument to make sure that the composite remains bonded to the tooth that we're restoring. We then very quickly light cure, and then I'd run a microbrush at the back just to remove any excess composite and then complete the light curing of the palatal incisal shelves. Following which, we should be left with two shelves that look like this, that are not bonded together. And these shelves provide us with a framework onto which we're going to apply our dentine shades and then finish the rest of the restoration. Now, as I mentioned, there are two ways in which we can rebuild the interproximal form. Either you do it straight away after this stage. So if I was to use it in this case, you'd place a mylar strip, secure that with a wooden wedge, and then restore the interproximal form. The alternative way of doing it is the delayed approach. So we build the interproximal following completion of the dentine buildup. So we use the delayed approach for this case, and now I'm ready to restore the missing dentine. So we use a single increment of composite, which is injected in the position that we want to place that dentine. We then manipulate the material using brushes, microbrushes, or modeling brushes. And in this particular instance, I decided to sculpt the dentine into 3 distinct mamelons. You want to make sure that the dentine doesn't extend towards the unprepared facial surface, because we need to leave 0.5 millimeters of space for the final enamel layer. I repeat the process on the adjacent central, and then light cure to hope to receive something that looks like this. I then added some white tints just to increase the halo effect, and sometimes you can use white tints just to accentuate any hypercalcification effects. And now we're ready to restore the interproximal. So once again, your options are we can either do it immediate or we can do it delayed. So the delayed approach happens once we've completed the dentine buildup. And the enamel shade that we're going to use on the facial surface is also used and placed in the interproximal area. So you can see here, I've restored the right central. I then place an acetate matrix and secure that with a wedge. We get a single increment of composite, and the reason why we use a single increment of composite is just to reduce the incorporation of air bubbles. We sculpt the material using a selection of hand instruments. And what you'll see next is I then paint the internal surface of the mylar strip with a modeling resin. Okay? What this allows me to do is pull the mylar strip from the buccal to the palatal, and what that does is it drags the interproximal composite and ensures that it is completely bonded with the palatal shell. And hopefully you should be left with something like this. The process was then repeated to restore the lateral incisors, and then we can go on to finish and polish the restorations. So I went through with a flat plastic interproximally just to make sure the teeth are not bonded. Quickly passed through some abrasive strips. We mark the line angles. We make sure we correct and restore the primary anatomy of the anterior teeth first, following which we then go on to do the secondary anatomy. Usually I like to finish and polish restorations using a selection of discs, but being a young patient, I wanted to impart some texture. So the finishing and polishing was completed using a coarse burr in a slow handpiece. And then I go through with a number 12 scalpel, just to remove any interproximal flash and any ledges. So here we have it, 3 shades of composite, 1 shade for the palatal shell, another shade for the dentine, and then a final shade for the enamel. Now, It's just as important to finish the palatal surface as it is to finish and polish the palatal surface, because in actual fact, patients feel the palatal surface way before you hand them a mirror to show them the transformation. So here are a couple of before and after pictures just showing what type of dentistry can be done using minimally invasive techniques, namely aligning teeth using conventional or more modern orthodontic techniques, followed by bleaching and bonding. And what you'll also find that now we've got hardcore evidence that these techniques also treat acne. The final layering technique that I want to show to you is this one. Now, what is the difference? Well, essentially, the configuration of the enamel layer is slightly different. So we restore the cervical and mid-third enamel with a chromatic microfill, and we restore the incisal third using an achromatic microfill. So what is the difference between a chromatic composite and an achromatic composite? Well, essentially, chromatic composites are usually Vita compatible. So any composites that is labeled as A1, A2, B3 is considered to be a chromatic composite, because those resins give us chroma and hue. Achromatic composites are usually described using terminology that is not Vita compatible. So it will either be incisal medium, junior enamel, adult enamel, or universal enamel number 3. And essentially what achromatic composites are designed to do is to impart some translucency in the incisal third, allowing all the effects and the chroma and the hues from the dentine to shine through to give us the effect of incisal translucency. Now, I generally only reserve this type of layering protocol when I'm treating teeth to restore adjacent natural teeth. As I said, the more teeth I restore, then I'm going to simplify the layering procedure. So here we have a case where we've got a patient who was referred to me by Lewis. So it's actually nice for you to see the end result of this case. Lewis referred this patient to me for management of the upper right one. And in actual fact, I think, Lewis, you've internally bleached it a few times and it's just relapsed. So when she came into the practice, she said to me, I want you to internally bleach it again. So I said to her, hey, look, the chap who's referred you to me, if he's performed internal bleaching, Lewis was the guy who taught me internal bleaching. There is no chance that mine's going to be more successful than his. So let's try an alternative technique. So my options here are either to restore this using a direct restoration or restore this and correct the dyschroma using an indirect restoration. Now, I needed a case for the management of the dark tooth, so you can see why I restored this with composite. So here we have the patient with a slightly high lip line. So the first step, once again, isolate with rubber dam, place floss ligatures, and then in this particular case, I used a 2-1-2 clamp just to provide further gingival retraction. Okay? So this allows me to extend the composite more subgingivally in order to mask the discoloration. I create a silicone index either from the pre-op or from a diagnostic wax-up, and then it needs to be trimmed and checked to make sure it fits within this butterfly clamp. The macro preparation was completed, and what I did was prepare a chamfer preparation in the cervical area, and we then sandblast the tooth structure to improve our bond strengths, and then we can then go on to etch and bond using the same protocol. We also removed the class 3 on the adjacent tooth. Then following etching and bonding, I then restored the palatal shell. So once again, we apply the nano composite onto the silicone index. We offer that up into the patient's mouth, light cure it to give us this shell. Now, the degree of dyschroma in this area is quite intense. So how do we mask that discoloration? Well, the best material to use is an opaque composite. And opacers can come in either conventionally filled in a conventionally filled form, or we can get flowable opacers. So in this particular case, we used a flowable opaker and we painted that in the cervical area. Following 2 layers, it was sufficient enough to block that discoloration. At which point I knew that as the base tone of the restoration was set, I can then go on not worrying about the dyschroma present. So the dentine is restored, again, using a nanocomposite, and then we go on to restore the enamel layer. So we leave about 0.5 millimeters of space. The cervical enamel is restored using a chromatic microfill, so that may be an A2 or an A3. We usually go for something darker in the cervical area, and we leave some space in the incisal area for our achromatic composite, because the achromatic composite is going to increase the amount of incisal translucency. Here is the build-up completed, and then we go on to finish and polish the restoration using a selection of discs, buffs, and polishing pastes. So here we are immediate post-op. You can see immediate rebound of the gingival tissues. And 8 months later, what we can see here is a nice integration of the resin within the patient's sexton. What's also quite nice to see is the biocompatibility of the microfill with gingival tissues. Because quite often when you use normal nanofilled or microhybrid composites, because they don't polish that well, they attract plaque and you're left with some gingival inflammation. But unfortunately, it didn't end too well with this tooth. This is the bit that you've not seen, Lewis. She attended 19 months later, complaining on pain on pressure. And hopefully you too can see the evidence of gingival pathology in this area. And it turned out that she had fractured the tooth, rendering it unsavable, and hence I needed to extract it. So, following extraction, I then sectioned the tooth so I can show you what that layering technique looks like from the perspective of a cross-section. Now, what was also interesting when I sectioned the tooth was to assess the fracture that had happened. Now, one would expect when a tooth fractures, it fractures at the narrowest point. And I would have expected that to be at the deepest part of my chamfer preparation towards the palatal surface. But in actual fact, the tooth had fractured slightly apical to that. So it may have fractured where forces generate at the cervical margin or where the bony crest is. But the best thing about this section piece was I was able to tell the patient, my restoration's fine. It's your tooth that's fractured, not my restoration. But in actual fact, the converse is more important. What we should be concerned about is not the longevity of our restoration, but the longevity of the tooth that we are restoring. We can keep replacing restorations, but we can't replace a tooth. So here we have the access cavity that's been restored with something. We've got the dentine here, the natural dentine of the tooth. We have the enamel. And then we go on to the restoration. So we've got my chamfer preparation just here. You can see the opaca that was placed to mask the discoloration in the cervical area. We then restored the bulk of the tooth with a nanocomposite. And we restore the incisal edge with the nanocomposite, and it supports the overlaying microfill. We can see the chromatic microfill applied in the cervical and mid-third, and as it tapers off towards the incisal area. And then finally, you can see this wedge shape of achromatic composite, which gives me the incisal translucency that we're after. So as I draw a conclusion to this lecture, just don't forget exactly why we're doing this type of minimally invasive dentistry. The whole point is we're trying to prevent the initiation of the restorative cycle. And if it has started, what we want to be doing is just reducing the rate of progression. Disease will always exist, whether it be tooth wear, caries, perio. The first line of approach should be always the most minimally invasive way, with direct composite. Once it's restored with composite, you can then go on to treat it with ceramic. But we know that when ceramic fails, preparations not only become bigger and deeper, ultimately the pulp will become irreversibly damaged, which you'll end up with root canal treatment, post-op cause, root fracture, and then we convince our patients to have implant treatment because they supposedly last forever. And then we figure out that they don't. Now for me, the tipping point in this restorative cycle is this area here, between the moment we cross between composite restorations and ceramic restorations. It's well established that repairing composites is much easier than repairing ceramic, and once you cross this border, there's no going back. Each speaker was asked, tell us an interesting fact about yourselves. And as Lewis alluded to, I am a drummer. So I was looking for a picture of me, just out of curiosity, of me playing the drums. And I was going through my laptop, and I found this image which really, really resonated with me. This is my niece. She's 2 to 3 years old back then, where she first picked up a pair of sticks. And now she's 12 years old, and she's taking on drumming lessons. And now I can see her developing into a drummer much better than I could ever be. But the journey that she's been through is exactly the same as what we go through. It starts off with inspiration. Lewis inspired me, and then it goes on to education. Okay, so we need to find something that we love. And once we've found that part of dentistry that we love, and for me it's direct dentistry, we can then go on to courses to develop our skills and really hone into it. The education is the simplest part, okay? Being inspired is being simple. Go to conferences, look on Facebook. Courses are also pretty simple. You just need to turn up and be educated. The hardest part of the whole thing is just putting it all into practice. That brings me to the end of the lecture. I hope you all enjoyed it, and I look forward to tonight's celebrations.